In this video, we are going to discuss about aspergillosis, not much of microbiological part, but more of clinical medicine part. So coming to the introduction, aspergillosis is caused only by those species that grow at 37 degrees centigrade and can cause invasive infection. Although some species without this ability can cause allergic syndromes. Now, what are the common aspergillus species that we need to remember? The most important one is Aspergillus fumigatus. We also have Aspergillus flavus, Aspergillus niger, then Aspergillus cereus, and Aspergillus nidulans. Of course, there are so many other species also. Now, Aspergillus fumigatus, this is the most common cause of invasive aspergillosis, the most common cause of invasive aspergillosis. Aspergillus flavus, they cause more of sinus infection, cutaneous infection, and ear infection, keratitis. So paranasal sinuses, skin, and ear. These are the three systems where Aspergillus flavus causes infection more commonly than Aspergillus fumigatus. Aspergillus niger usually causes invasive infection. More likely causes otitis externa. Okay, otitis externa. Aspergillus terreus, it causes invasive infection, only invasive infection, and it has a very bad prognosis. Aspergillus nodulans causes invasive infection primarily in patients with chronic granulomatous disease. This is important. Chronic granulomatous disease, Aspergillus nodulans is the responsible disease. Now, coming to the risk factors and pathogenesis, usually it causes infection in immunocompromised patients. So, the patients with profound neutropenia, so absolute neutrophil count is reduced, or patients on steroid therapy. Patients with dysfunctional neutrophils or phagocytic system, dysfunctional neutrophils or dysfunctional phagocytic system. For example, patients with chronic granulomatous disease, advanced HIV cases, or acute leukemia cases. Then patients with prior pulmonary disease like pneumonia, bar COPD. Here also you can write patients on chemotherapy. And patients with severe liver disease, or iron overload states. Then patients with influenza infection, or patients on ECMO therapy. Developing allergic bronchopulmonary, there are two other entities that you have to remember. For developing allergic bronchopulmonary aspergillosis, the risk factor is either asthma, bronchial asthma, or cystic fibrosis. For developing CPA, that is chronic pulmonary aspergillosis, there might be prior history of TB, COPD, or prior pneumothorax. So these group of patients, they might not be immunocompromised, but still they're predisposed to aspergillosis, some kind of aspergillosis. I'll start with the clinical features. We'll start with the involvement of lungs. It can be divided into four groups. One is the invasive group, invasive pulmonary infection. Second one is the chronic pulmonary infections. Third one is saprophytic pulmonary infections. Fourth one is allergic pulmonary infections. This acute or invasive pulmonary infections, it can also be divided into acute bar subacute. Acute is less than 1 month, and subacute is 1 to 3 months. Usually these patients are angio-invasive. Usually these infections are angio-invasive. That is the reason for causing necrosis. That is the reason for causing hemoptysis. Okay, so usually they are angio-invasive in nature, but it can also be non-angio-invasive. Usually present with fever, cough, so symptoms of pneumonia, so fever, cough, shortness of breath, hemoptysis, etc. Diagnosis, we'll find, I'll be discussing the radiological finding later. So this is about the invasive infection. Now they can have chronic pulmonary infections also. It is again three types: chronic cavitary type, chronic cavitary type, which is very much similar to tuberculosis, which is very much similar to tuberculosis. Usually these patients will have a prior history of tuberculosis or non-tubercular mycobacterial infection or rheumatic lung disease. Okay, you may get a fluid level. You may get a fluid level. This infection is caused most commonly by Aspergillus fumigatus rather than any other species, and it is followed by Aspergillus niger. Okay. So most commonly it is caused by Aspergillus fumigatus, and the second most common organism that causes chronic cavitary aspergillosis is Aspergillus niger, and this Aspergillus niger, it causes this chronic cavitary infection most likely in patients with diabetes or oxalosis. Diabetes or oxalosis. IgM antibody is positive. IgM antibody is positive in 95% of cases. Remember, in acute or invasive cases, you may get culture positivity, but in chronic cases, culture positivity is very unlikely. So, in those cases, the diagnosis mostly depends on the antibody levels. Then the second chronic type is Aspergillus nodule. Aspergillus nodule. In this case, you will get IgG antibody positivity in 65% of cases, and this will mimic CA lung, carcinoma lung. I told chronic cavitary will be similar to tuberculosis. It will mimic radiologically tuberculosis. Nodule will mimic carcinoma lung. Then the third one is chronic fibrosing type. Chronic fibrosing type. Remember, aspergillosis will cause upper lobe fibrosis. Upper lobe fibrosis. Now these are the chronic manifestations in the lung for aspergillosis. Now coming to the saprophytic type of infection. The first one is aspergilloma. Aspergilloma. Aspergilloma is usually a late manifestation of aspergillus infection. These patients will present with cough, hemoptysis, and constitutional symptoms like weight loss. Okay, and other symptoms like fatigue and other constitutional symptoms. And here, the management is surgery. If it is a single aspergilloma is otherwise known as the fungal bulb. It is otherwise known as the fungal bulb. If it is a single aspergilloma, you can do surgery. If it is multiple aspergillomas, then surgery also will not be much helpful. Around 10% of the cases resolve spontaneously because of coughing. So around 10% may resolve because of coughing out the nodule. However, the cavity will remain infected. Okay, the cavity will remain infected. Second one is just simple airway colonization. Simple airway colonization. Coming to the allergic variety of infections, this include ABP, allergic bronchopulmonary aspergillosis. This I'll be discussing in detail in the next slides. Then we have severe asthma with fungal sensitivity, with fungal sensitization, SAFS, severe asthma with fungal sensitization. So this is actually very much similar to ABP, allergic bronchopulmonary aspergillosis, but not meeting the criteria of ABPA. Criteria will be seen subsequently. So here SAFS is the term used when the features are very much similar to ABPA, but the criteria of ABPA is not fitting. Then the last one is extrinsic, allergic, alveolitis. So these are all the different types of manifestations of Aspergillus lung. Now next we will be discussing about ABPA a little bit in detail. So allergic bronchopulmonary aspergillosis, the type of allergy or hypersensitivity reaction that is seen is type 1 more than type 3. So both type 1 and type 3 is in type 1 more than type 3. Because of type 1, we will have more IgE levels. Because of type 3, we will have IgG precipitants. Here, these patients will have a pre-existing. So ABPA develops in patients who have pre-existing cystic fibrosis or bronchial asthma, cystic fibrosis or bronchial asthma. So in any patient with cystic fibrosis, bronchial asthma, if they have a recurrent exacerbations in patients with bronchial asthma, if they have a recurrent asthmatic attacks, or if the bronchial asthma is dependent on steroids. So if it is recurrent, if you have recurrent attacks, or it is steroid dependent, then you will suspect a case, you will suspect allergic bronchopulmonary aspergillosis. Here there is profuse production of profuse mucus production that leads to plugging of bronchus, and this plugging of bronchus, this bronchial obstruction will lead to bronchiectasis. So BPA is an important cause of bronchiectasis. Okay. Clinical features I have already told. If the patient has cystic fibrosis or bronchial asthma, they will have recurrent attacks, and bronchial asthma becomes, if it becomes steroid dependent bronchial asthma, then you have to think of ABPA. Okay. And I told they will have uh, profuse mucus expectoration. Clubbing may be seen in 15% of cases. Okay. Now regarding the imaging, if you want to remember about the PFT finding, pulmonary function test findings, so you will get mostly obstructive pattern, but ABPA in the long run will cause lung fibrosis. So in stage 5, you may get a restrictive pattern. You may get a restrictive pattern. Coming to the radiological findings, because of the massive mucus production, this mucus will cause bronchial clogging, as I have already told. As you can see here, this is the bronchial clogging by the mucus. All the images are showing the same thing. So this is described as finger in glove appearance. Okay, so this is finger in glove appearance. It is also known as toothpaste shadow. Toothpaste shadow or tram track lines. And this ABPA can also produce tree in bud appearance. Tree in bud appearance. Coming to the criteria. Coming to the criteria for ABPA. Criteria has the first component is predisposing factor. Predisposing factor. Second component is obligatory criteria. Obligatory. Third component is other criteria. So predisposing factor, either one of them should be present, that is cystic fibrosis or bronchial asthma. Obligatory factor means both of them should be present. Both should be present. One is Aspergillus skin test should be positive. Aspergillus skin test should be positive, or IgE specific against Aspergillus should be present. The second one is total IgE levels. Total IgE should be more than 1000 international unit per ml. So total IgE should be more than 1000 international units per ml. I told that severe asthma with fungal sensitization, SAFS. This is also very much similar to ABPA, but it will not meet the criteria, and the most common criteria that is used is this. If the total IgE levels are less than 1000, we call it as SAFS, and if it is more than 1000, it is more in favor of ABPA. These are the two obligatory criteria. Then other criteria include uh, uh, radiological evidence, radiologic evidence specific for Aspergillus. Then total eosinophil count more than 500 per microliter. Total absolute eosinophil count more than 500, or IgG precipitin, IgG precipitin against Aspergillus. Against Aspergillus. Among these three, two should be present. 2 out of 3. So among the predisposing factor, either cystic fibrosis or bronchial asthma should be present. Among the obligatory criteria, both criteria should be there, and among others, 2 out of 3 criteria should be there. Radiologic, eosinophil more than 500 of precipitants, IgG precipitants against Aspergillus. Coming to the treatment, is the most important treatment is systemic steroids, systemic glucocorticoids. Okay, it should be given for 3 to 6 months. 3 to 6 months. Antifungal agents can be given along with steroids. Antifungal agents, mostly the voriconazole or itraconazole, can be used. It is given as a 4-month therapy. Then, if it is not effective, then you can give IgE monoclonal antibody against IgE monoclonal antibody, that is omalizumab. So this is the treatment, and the most important drug is steroid. Monitoring of response is done through monitoring of IgE levels. This is all about ABPA. So we have discussed everything about the lung manifestations of Aspergillus. Now coming to the PNS, or paranasal sinus involvements. It is divided into 3 groups: invasive, chronic, and allergic. Invasive, chronic, and allergic. So invasive, it is acute, mostly seen in cases of acute leukemia, or patients with hematopoietic stem cell transplantation, or patients on chemotherapy. If you do endoscopy, if you do nasal endoscopy, you will get dusky necrotic material, dusky or pale necrotic material. Chronic, again they can have fungal ball, or it can be of chronic invasive type, or it can be of chronic granulomatous type. Fungal ball is more common in maxillary sinus. But invasive form is more common in ethmoid or sphenoid sinus. More common in ethmoid sinus, not maxillary sinus. Okay. So fungal ball is the usual history for fungal ball is prior upper jaw or root canal surgery. Okay. So patient will have history of prior upper jaw root canal surgery. This is a typical history for having a fungal ball, and the treatment for this is surgery. In fungal ball inside the lung, aspergilloma, also the treatment is surgery. Chronic invasive variety, usually it affects ethmoid or sphenoid sinus, and their usual presentation is orbital apex syndrome, or cavernous sinus thrombosis, orbital apex syndrome or cavernous sinus thrombosis, or facial swelling, with facial palsy. With facial palsy. May have a skull-base invasion also. They may have skull-base invasion also. Chronic granulomatous infection usually caused by Aspergillus flavus. Usually it is caused by Aspergillus flavus. Then coming to the allergic infections, they can cause chronic sinusitis, chronic allergic sinusitis, and the histopathological hallmark is Charcot, Charcot Leyden crystals, Charcot Leyden crystals. Coming to other organ involvement, it can involve brain, where it can cause acute infection, can cause abscess, meningitis, or infection because of its angioinvasive nature. And chronic Aspergillus infection can present as granulomatous lesion that will mimic as brain tumor, Skin involvement, acute skin involvement, it can be disseminated skin involvement. They present as multiple necrotic scar, or they may present as locally invasive form, which is associated with IV line associated locally invasive form may be seen. And here the most common organism, this is also caused most commonly by Aspergillus flavus. I told sinus, skin, and ear. These three infections are more common with Aspergillus flavus. Chronic skin involvement is seen as in the form of onychomycosis, nail infection, onychomycosis, or external otitis. CVS or heart, they will be present as endocarditis, usually culture negative endocarditis. Okay. Then ophthal involvement, they can cause keratitis. The typical history will be injury by the vegetative matter, or they can also cause endophthalmitis. So we have discussed about the clinical manifestations of Aspergillus. The second part will be discussing about the management of Aspergillus.